In this episode, you are going to hear from a cardiologist that talks about why saturated fat may not be the main culprit of heart disease. If your doctor told you that your cholesterol is too high and that you may need to get on a statin, or if heart disease runs in your family, or finally, if you're just not sure if this way of eating is good for heart health, I highly recommend watching this video. You will learn many different facets of what really causes heart disease and what are the best predictive indicators that may cause heart disease more than just looking at cholesterol and then worrying about saturated fats. Hey guys, my name is Judy Cho and I'm board certified in holistic nutrition. And I have a private practice where we focus on root cause healing. And that often starts with the Carnivore Cures all meat elimination diet. Today, I had the pleasure of sitting down with Dr. Philip Ovadia. I had him on right when he was releasing his book, Stay Off My Operating Table. And I highly recommend getting it if you haven't checked it out. In this interview, we talk about all things heart health. We know that there is more and more heart disease than ever before. And yet we have been on the low fat craze. We have been on statins, and yet heart disease is not going down. So what is the culprit of causing heart disease? I can think of some in more recent years, but beyond that, what else is causing heart disease? I hope this interview gives you a lot of answers in figuring out how you can test for heart disease, what you can consider in terms of lifestyle for heart health, and what you can do to protect yourself. Okay, guys, let's get right into the interview. Hi, Dr. Ovadia. It's so good I think I interviewed you 2 years ago, right when your book was about to come out. So, like, what a progression in terms of the success of your book and then your podcast and all of these exciting things. But for the people that may not have watched our first interview, if you can introduce yourself.
Yeah, it's great to be back here with you again, Judy, and congratulations on your recent book. And it's amazing how quickly time flies with things like this. People always ask me, oh, how long ago was that? And I'm not very good with time frames. So if you had asked me, I would have said, oh, I probably was on with Judy a year or so ago, but amazing to think that it's been 2 years and everything that's happened. So for those of you who aren't familiar with me, Dr. Philip Ovadia, I've been a heart surgeon now for over 20 years. And for much of that time, I was a very unhealthy heart surgeon. I had reached a point that I was morbidly obese, pre-diabetic, and recognized that I was going to end up on my own operating table, so to speak. I was traveling down the same path that so many of my patients had traveled down, and I was kind of at a loss because I was following the advice that I had learned to give, the eat less, move more, eat a low fat diet. It wasn't working for me. It wasn't working for my patients. And thankfully, I came across new information, started asking different questions, ultimately, started on a low carb diet that evolved now to really a carnivore diet, and I was able to lose over 100 pounds. I've maintained that weight loss now for coming up on 8 years. And along the way, I realized that what I had been taught about the disease that I had dedicated my career to fighting, heart disease, was not exactly what I had been told. And so kind of refocus things. I continue to work as a heart surgeon, but increasingly am focused on keeping people off my operating table. And that's the name of my book, Stay Off My Operating Table. Now run a very busy telemedicine practice that I work with people across the country, across the US and internationally, on keeping them off the operating table and trying to prevent and reverse heart disease rather than having to operate on it.
Well, thank you for sharing that. I love that you have pivoted from just the conventional care of certain recommendations. And I'm guessing that you probably don't recommend people to stop eating meat. So my guess is that you don't think cholesterol is bad, or maybe there's context to that. But why do we think that for heart health, we should stop eating cholesterol and saturated fats?
Yeah, this is really a complicated, convoluted story. And, it's interesting when you really look at the scientific literature, there's no reason that we should believe that. There really is, the evidence does not support that conclusion. And this has now been shown in multiple large, what we call meta-analyses and, interventional trials. And it was really just poor science, honestly, combined with almost a religious pursuit of this idea that got us here in the first place. Many people are probably familiar with the story of, Ansel Keys, who was really the first scientist that strongly promoted this idea that saturated fat in the diet was causing the epidemic of heart disease that we were seeing in this country in the 1950s. This really reached a crisis point in 1955 when President Eisenhower, while in office, had a heart attack. And that appropriately set off the alarm bells. And Ansel Keys, who was kind of a fledgling scientist at the time, just really promoted this hypothesis about saturated fat and blamed President Eisenhower's heart disease on saturated fat, despite the fact that President Eisenhower was a heavy smoker, and that was sort of the obvious cause for his heart disease. And then, he set off on a scientific mission to prove his hypothesis. And really, when you look at the work that he didn't really stick well to the scientific method, we'll say, but he was able to gain a lot of political power and really, use some sort of heavy-handed techniques to quash anyone who questioned his hypothesis. And, from there, basically industry got involved, the food industry got involved, and then the pharmaceutical industry got involved. And, when I went through medical school in the 1990s, early to mid 1990s, it was an unquestioned fact. It was not presented to me as hypothesis. It was presented to me as fact, as cholesterol is the cause of heart disease. And the primary way that we can manage heart disease is by managing cholesterol levels. And of course, I and many others have now come to discover that that's not really the whole story.
And then in medical school, do they teach so if I went to medical school today, would the same narrative be continued? So would they still say to me, to reduce heart disease, I would have to reduce my cholesterol levels?
Yeah, most definitely. And that's what all of our practice guidelines are centered on. And, I want people to understand that it's not that I'm saying that cholesterol has nothing to do with heart disease. It's just that cholesterol shouldn't be our primary focus when it comes to heart disease. And a blanket lowering of cholesterol levels isn't really what we need. When I talk about cholesterol, it's in the context of our cholesterol quality matters. It's not really our cholesterol quantity that matters.
Okay, so then if I were to work with you and you were my heart doctor, what would you look at in my life or maybe diet or, any other thing in part of me to make sure that I have good heart health?
Yeah, so, the first thing that I think, where my messaging might differ, and the first thing that I do differently in practice than much of the cardiology community is, blood work is okay, and it gives us some indications, but it really doesn't tell us, do you have heart disease or not? And so one thing that I emphasize to people is, if you want to know if you have heart disease, let's get a test that actually looks at whether or not you have heart disease, not risk factors for heart disease. So the test that I advocate for strongly and use liberally with my patients is what's called a coronary artery calcium scan. And this is a type of imaging study, a type of CAT scan that actually looks at the arteries of the heart and looks for evidence of plaque in those arteries, specifically calcified plaque. So that's really step number one. And then, the primary risk factor for heart disease from a dietary standpoint, or sort of from a physiologic standpoint, I'll say, is insulin resistance. And so the main thing that I'm looking for is insulin resistance. And we can certainly get into why insulin resistance is so important. But study after study, really every study that I have ever looked at that compares insulin resistance to cholesterol levels in terms of their magnitude of risk for heart disease, it's not even close. Insulin resistance is 5 to 10 times more important more powerful a predictor of heart disease risk than cholesterol levels are.
The CAC score, the coronary artery calcium score, most people want the 0. And then 0 is like, okay, cool, I'm safe, I have good heart health. But then some people will get the test and maybe they have some numbers. Because some people will say to me, I have a calcium score of 100. And so therefore I shouldn't go carnivore because I already have plaque and I'm really scared. And my doctor is scaring me that if I eat more cholesterol, it's going to worsen it. So what should I do? What should they do in that instance?
Yeah, so if you have a non-zero score, the goal is you want that score not to get worse over time. And again, cholesterol and a low fat, low cholesterol diet is not the answer. It doesn't work. We have plenty of data showing us this, but controlling insulin resistance is what you should be focused on. And the best way we have to control insulin resistance is a low carbohydrate dietary approach. And that includes a carnivore approach. And really, again, there's no reason that we should be fearing red meat or cholesterol in the diet. Red meat has now, again, clearly been shown not to be a risk factor for the development of heart disease. Red meat by itself, I'm going to say. Red meat as part of a Western diet has been implicated in heart disease and many other disease processes. But again, it's not the red meat itself. It's what people are eating with the red meat. The French fries, the soda, the toppings, the bun. That's the real problem. It's not, and it's never been the red meat itself.
So we don't run a lot of scores because I mean I'm not a doctor, but we'll see people have the score, but we see a lot of insulin markers. Have you seen that if a certain person has a insulin resist or an insulin marker of over a certain number, that there's a higher chance of there being plaque in their arteries?
Yes, insulin resistance, and there are a number of ways that you can look at that from a laboratory standpoint, is clearly associated with not only the presence of disease, but the progression of disease. And again, no matter what your score might be today, if you stop it from getting worse, that's going to put you in a better place. So I look at various markers of insulin sensitivity. You can start with, if all you have is a basic lipid panel to look at, for instance, which some patients are limited to for whatever reason, just look at your triglyceride to HDL ratio. And you want that to be less than 1.5. Anything over 2 for that ratio means that you're likely to be insulin resistant. Now, ideally, you're going to get better markers of insulin resistance. So this starts with a fasting insulin level. And if you have your fasting insulin and your fasting glucose level, you can calculate what's called the HOMA-IR score. And you can, there are numerous calculators online that you can just plug in your insulin and your glucose values. And again, a HOMA-IR score of greater than 2 is an indicator that you're insulin resistant. If you can take it to the next step, even better, is what's called a lipoprotein insulin resistance score, LPIR score. And what this score does is it looks at the size of your cholesterol particles. And I mentioned earlier in the talk how important cholesterol quality is. And it turns out that insulin resistance is the primary influencer of the quality of our cholesterol particles. So Dr. Bill Cromwell was really the one that pioneered this, and he was smart enough to figure out that you can work in reverse. You can look at the size of people's cholesterol particles and use that to determine if they are insulin resistant, because that relationship is so strong. And so the LPIR score, I think, is the best practical way for us to measure insulin resistance. And I'll mention kind of what the gold standard way of diagnosing insulin resistance is. It's what's called a Kraft test, but it's kind of an impractical test to do. You basically have to drink a solution of sugar, of glucose, and then you have to measure both your insulin and your glucose levels every half hour for 3 hours afterwards to really, figure out a proper Kraft test. So that becomes a little impractical to do. And I think today, if, what the best lab test is for insulin resistance is the LPIR score.
So, what's so interesting is occasionally we will run a more comprehensive cholesterol panel that has the NMR graph with all the different size particles.
Mm-hmm.
And what we find is in that the LPIR is a little bit closer to more insulin resistant, but their fasting insulin is normal. So then we were always like, what does that mean? So it looks like you have the answer to that.
Yeah, and really, again, Dr. Kraft, Joseph Kraft, figured this out because when you look at the Kraft patterns, so there are 5 patterns that you can get on a Kraft test. And, 2 of the patterns that define insulin resistance, you actually start with a normal fasting insulin. So having a normal fasting insulin level doesn't guarantee that you're insulin resistant, that you're not insulin resistant. Now, if your fasting insulin level is elevated, that does show you that you're insulin resistant, but you can have a normal fasting insulin level and still be insulin resistant, when you do a full Kraft test, or now, like you said, the LPIR score will reveal that as well.
Yeah, and that makes a lot of sense because we tend to see the fasting insulin because someone's carnivore, they've been eating this way for a while. So now their fasting insulin has come down. And we were always perplexed with, well, that's interesting because their PIR score shows that they're still insulin resistant. So I guess that is more of maybe a better marker to look at long term.
Yeah, I think so. And, again, you can then correlate this with things like visceral fat levels, which are, very strongly associated with insulin resistance. And, oftentimes I'm kind of putting all of these things together. I always tell people, understand that there's no one test that tells you, am I healthy or not? And that's kind of the fallacy of well, let's just look at your LDL cholesterol, and that's going to tell us everything we need to know about heart disease. I mean, it really is nonsensical. Heart disease is such a complex process. To think that one lab test is going to tell us everything we need to know, it really was just a silly concept to start with. Yet here we are, and most doctors firmly still believe that, just look at the LDL cholesterol and you're going to be able to tell if someone's at risk of heart disease or not.
Right. And it's so unfortunate because we see people turn carnivore. They're like, oh my gosh, all my symptoms are better. I'm sleeping through the night. I'm losing weight. I feel so much better. And then they go and do their blood work next to their total cholesterol or their LDL cholesterol. It says H. And they're like, my doctor says I need to get on a statin now and I need to change my diet. And even though a lot of their symptoms have improved, now they are so worried that they need to get on medication. You talked a little. Go ahead. Go ahead.
I was just going to say that really is unfortunate. And especially people who have, very strong reasons for, needing to do a carnivore diet.
Right.
For instance, they have severe autoimmune conditions that are really being benefited by this dietary approach. And they're basically scared out of it by their doctors who don't understand, what this number means or doesn't mean.
Right. Agreed. Totally agreed. So it sounds like some cholesterol may not be as ideal. Can you talk through a little bit about what do you mean by the quality of cholesterol?
Yeah. So, when we look at, our blood cholesterol measurements, HDL, LDL are the ones that people are going to be familiar with. And, we're told that HDL is good cholesterol and LDL is bad cholesterol. And again, that really, that concept is very flawed. Both HDL and LDL represent families of cholesterol carrying particles in the bloodstream. And, one of the ways to sort of further break down our cholesterol particles is by their size. And specifically, when we look at LDL cholesterol, this is most relevant for, we know that there are small, dense LDL particles, and there are large, buoyant or large, fluffy LDL particles. And furthermore, what we know is that it is only the small, dense particles that end up in atherosclerotic plaques. The large, fluffy, large, buoyant particles do not get incorporated into atherosclerotic plaques. So this is the problem with just looking at the LDL level as an overall level. We don't know Is it high because you have a lot of large, fluffy particles, which I would put forth as not a problematic situation? And even if your LDL level is what's considered low, in the target range, if you have a low amount of LDL cholesterol, but most of that LDL is small, dense particles, you are still at risk of heart disease. And this is why I see people ending up on my operating table, despite the fact that they've had low, well controlled in the guidelines LDL cholesterol levels for decades in many cases. And yet they still end up with heart disease. They still end up on my operating table.
Some people say that certain genetic types, so I think it might have been the ApoE gene, but
Mhm.
they're not able to tolerate as much saturated fat. Have you seen that in your practice with heart health?
Well, I think that concept is flawed as well, honestly. And we're still really trying to figure out, what ApoE genetics mean. The biggest concern around them has been that if you have what's called a double ApoE4, that, you're at increased risk for Alzheimer's disease, increased risk for heart disease, and that, it's been put forth that you're in some way, abnormally susceptible to saturated fat. But if we step back, it really doesn't make sense for that to be the case, because we have to realize that, these genetic types, have been selected for over, millennia, over our existence as human beings. Genetics don't really change quickly across a population. So ApoE4 would have survived in the population at a time when humans were eating primarily saturated fat. Because for most of our existence as human beings, we ate primarily saturated fat. And so, I do have a number of patients that do have, the double four, ApoE4, and they're doing these diets, and we're monitoring them closely, and they don't seem to be, developing accelerated heart disease in my experience thus far. So I don't think, it's really the whole story as we've been told that it is.
Do you find any type of person that if they went strict carnivore, that for your genetics or your something that you probably shouldn't eat this way, at least for
I
heart
am
health?
Yeah, I'm really yet to come across
Okay.
that. Honestly, some people, the adaptation to a carnivore diet might take a little bit of finesse. And, some people, yeah, when they first try it, it doesn't exactly agree with them. And we might have to play around with things. But I'm really yet to find a person that, for some reason couldn't do a carnivore diet, or, whatever conditions got worse on a carnivore diet. And, I am always kind of a little cautious about this. I'm always on the lookout for it because, I say to myself, well, it kind of sounds crazy, every condition that people come to me with, and they're like, well, can a carnivore diet help this? And I'm like, well, it can't help everything, right? But lo and behold, I usually will get online and I'll go to some of the communities and I'll see what people are reporting. And most of the time, you can find someone who says, yes, this got better on a carnivore diet. So my default these days is basically to tell people, the only way we're going to really know if you're going to get better or not on a carnivore diet is to try a carnivore diet. And I'm also open and honest with people. And I say, most people don't need to be on a carnivore diet. I think there are certain conditions that, yes, carnivore diet is very necessary. And these are a lot of the autoimmune conditions, people with bad gut problems. Those are the people that I'm like, you need to be on a strict carnivore diet, at least for a while. Other people, I just want them to understand it's an option. And, I say, let's give it a try, give it 30 days, give it 60 days, see how you feel. And at that point, it's almost universal that if the person does it and they're able to adhere to it, they feel better after 30 or 60 days. And then it's like, do you want to stick with it? Do you not? Do you want to add back a few things selectively, which some of them do? And we do that carefully and they're okay with it. So like, I don't tell people that carnivore is the only way to be healthy. I just want people to understand that it's an option.
Yeah, I love that. I mean, our practice uses carnivore as an elimination diet, and for the same population that you're mentioning. And for some people, they have to go strict because they're trying to figure out, is diet part of my inflammation? And so I think that totally makes sense. And then as you heal, if you want to add some other stuff back in moderation, then maybe it's okay, but everyone's individualized. And I think in your book, you touch upon that certain diets, you can do it in certain ways, but the goal is to really get off a lot of the processed carbs and the foods that are really adverse to your heart health. I wanted to ask you if you've seen some people reverse their heart disease. So some people always ask me if you can improve your arterial health. I know that you can overall improve heart health, but have you seen cases where your arteries can improve as well?
Yeah, so we have seen some cases where coronary artery calcium scores decrease.
Okay.
And that's very controversial to say, but I've seen it. Is all I can say. Okay. And there's always question, understand that if you get 2 coronary artery calcium scans, even if you get them done on the same machine, one right after each other, there's variance, like there is in every measurement. And so 5-10% variance, you could probably chalk up to, just a difference in technique. But I've seen people now that, have 15-20% lowering of their CAC score. I don't see people go from 1,000 to 0, but I think you can lower this some. More important, though, is just stop it from getting worse. Again, we have a lot of data to show that, when you look at serial coronary artery calcium scanning over time, the average progression is about 15 to 20% per year.
Wow.
And we have data that if your score goes up by less than that, if it doesn't progress that quickly, that no matter what your absolute score is, it puts you into a lower risk category. So, the way that I utilize coronary artery calcium scanning in my practice is most of my patients, we get their kind of baseline scan when they come into the practice, and then we get a scan a year later. And what we're looking for is that score hasn't gone up. And like I said, we've seen a few cases where it's gone down. And for the most part, if they've addressed their insulin resistance, if they've been able to reverse their insulin resistance, if we eliminate other sources of inflammation, we see that the score doesn't progress.
What do you think of? So we've had a couple clients that will bring us their score and it's a 0, but their blood sugar is going up a little bit on carnivore and they are scared that they are becoming insulin resistant, even though some of these other markers are showing healing and benefit. Would you worry about a slightly increasing, and maybe we could put a number to it, maybe their blood sugar in the morning is about 100. Would you be worried about that?
Usually not. I think this is a common thing that I see as well in my practice. And there are some things that you can do, playing around with kind of fat to protein ratios and, fasting windows and stuff like that can help bring down the glucose. But generally, if everything else looks good and, usually with those people, again, I'm very liberal about using continuous glucose monitors. So, if your blood sugar is kind of a flat, 100-ish throughout the day, I don't think that's something we need to be too worried about. But, I want to make sure that they're not, again, check the LPIR score. And then we're going to follow that coronary artery calcium score over time. Even if you have a 0 score, I still want to make sure that you're staying 0. And maybe in that situation, we may not check it every year. Maybe you go 2 or 3 years. A lot of it's going to depend on the age of the patient and, again, what these other markers look like. Because even if you have a 0 score, if, you are insulin resistant, if your LPIR score is abnormal, you have other, features of insulin resistance, then, I am worried about that person. And the 0 score still doesn't really reassure me because we can be fairly certain in that scenario it's not going to stay 0.
Right. So from what I'm hearing from you, the scan, do you do it on any person in terms of age? So if someone's in their 20s, would you also do the scan? And then how often do you do it? It sounds like if someone's at a 0, you don't do it every year, but how often do you typically do it as well?
Yeah, so my general guidelines is, men should probably get their first scan around the time that they're 40, and women probably around the time that you're 50. If you have, reason to be concerned, you have a strong family history, if you know you're insulin resistant, if you've been a smoker, something like that, then get the scan earlier. It's really never too early to get the scan. It's just a matter of the zero score. The younger you are, the less significant having a zero score ends up being. So, yes, I've had some people that are in their 20s and 30s and were worried for some reason, and we get a scan. Understand that as a heart surgeon, I now operate on 30-year-olds. Like, they end up on my table with advanced coronary disease. So it's certainly possible, that you have heart disease in your 20s and 30s. And the earlier we find out about it, and this is the other part of this to understand, if you're young and you have a non-zero score, even if that score is very low, like 5 or 10, that's a major, major red flag. Because if you're 20 or 30 years old and you've already started forming plaque, we have a big problem that we need to get on top of before, you end up as one of those 30 or 40-year-olds on my operating table.
When these patients of yours at the age of 30 are having to operate on their heart, is it primarily like what is the cause of their insulin resistance or their heart having these imbalances? Is it primarily their diet? Is it also stress, smoking? I mean, what are some of these major contributors?
I mean, all of the above certainly contributes, but I think diet is still first and foremost. And these are people who, likely have been insulin resistant from a very young age. And again, we're seeing this. We're seeing teenagers and even pre-teenagers diagnosed with type 2 diabetes, not type 1 diabetes, type 2 diabetes, which means that they've been insulin resistant from very early on. And we know, for instance, that, if your mother is insulin resistant while you're in the womb, that's going to make you more prone to being insulin resistant. And, some of these, some of these children, unfortunately, that are born under those circumstances, and then they're really fed sugar from birth. And a lot of the things that kids get fed these days are just, very high sugar, and they get insulin resistant very young. And these, I think, are the 30-year-olds that are, now ending up on my operating table.
Correct me if I'm wrong, but you don't have to be overweight to be insulin resistant.
Yeah, very true. Again, we can look at, for instance, the NHANES data that was published, back in 2019. This is the study that everyone quotes, saying 88% of adults in the United States are metabolically unhealthy. And in that study, they broke it down by, body weight categories. And even when we look at the people that were normal weight, about half of them were metabolically unhealthy. So not being obese does not guarantee that you are insulin sensitive. Of course, being obese almost guarantees that you're insulin resistant. There are a few people who are obese and not insulin resistant, but being obese almost guarantees that you're insulin resistant, but not being obese in no way protects you or guarantees that you're not insulin resistant. And this is why you got to get the testing to figure out if you are or not.
Two things that I've heard recently that are interesting that also supposedly contribute to heart health imbalances are sleep apnea and oral hygiene. Can you share a little bit about why both of them would affect your heart health?
Yeah, definitely. They are both strongly associated with heart disease. And there may be a couple of things going on here. Number one is that insulin resistance, it turns out, is a underlying, risk factor root cause of sleep apnea, as well as periodontal disease. A few weeks ago, I actually was talking to a conference of periodontists and, went through all of the literature about the associations between periodontal disease and heart disease. And it turns out that, insulin resistance is a common root cause there. Most people with periodontal disease are insulin resistant, and therefore they're also at risk for heart disease. Now, there have been some other theories about, the periodontal disease introducing bacteria into our bloodstream, which then causes inflammation that damages the blood vessels. And there's probably some validity to that as well. The kind of scientific evidence to support that is that when they look at atherosclerotic plaques, oftentimes there are bacteria in them. And many of the times, those bacteria are the same bacteria that we see in the mouth. So that may be playing a role as well. When we look at sleep apnea, again, sleep apnea is strongly associated with insulin resistance and may be an indicator of insulin resistance. But sleep apnea is also going to be putting extra stress on your heart. Basically, every time you stop breathing, during the night when you have sleep apnea, that's going to cause usually your blood pressure to go up, your pulse rate to go up. It's going to be putting physiologic stress on the heart, which can contribute to the development of atherosclerosis as well.
With the dental work, I did hear about the bacteria. Do you think it's more of the insulin resistance that's causing the issues more than the bacteria in the blood?
Yeah, I do think it's more so the insulin resistance that's shared between the two diseases that causes that linkage.
Okay, that makes a lot of sense. I'm going to ask you about statins because it's everyone's favorite drug. What are your thoughts on it? Are there certain people that should be on it? What if people aren't willing to change their diet? Any of your thoughts?
Yeah, so that's exactly kind of how I look at this. If you have high cholesterol, high LDL cholesterol, and you're insulin resistant, that's a problem because, again, it's very likely in that scenario that you're going to have the poor quality, the small, dense LDL cholesterol. So if you're not going to do something about the insulin resistance, then yeah, take a statin. It's going to give you a little benefit. And people need to understand that that benefit is very little. It's nowhere near the big numbers that are thrown out there, 30%, 50% reduction in disease. Those are, that is statistical manipulation where they use something called the relative risk reduction instead of the absolute risk reduction. So when you look at the absolute risk reduction, the true reduction in risk, the numbers are more like 3 or 4%, which of course sound nowhere near as impressive. And the flip side of that is, if you're taking these medications for decades, you're exposing yourself to the negative effects of these medications. And one of the most prominent negative effects of taking statins over the long term is that it increases your risk of becoming insulin resistant. It increases your risk of developing type 2 diabetes. And since these are primary drivers of heart disease, this is why I think the overall, data on statins is so disappointing because maybe it's, lowering your cholesterol level a little bit, but if, at the same time, it's making you more insulin resistant, it really may be increasing your risk of heart disease, as a net effect. So, there are perhaps some other scenarios, but, again, I have the conversation with patients about insulin resistance. Let's address that. And once you're no longer insulin resistant, we've really never shown any benefit to taking these medications, in that circumstance. And so put yourself in a position where the medication is simply not going to be a benefit for you. And I think that's the best answer. But if you're not going to do that, then yeah, there may be some benefit to taking these medications.
So the research I did on statins, I guess there was insulin resistance. What I do remember is that it causes a lot of muscle atrophy. And then most people that take statins are older and you're already suffering with sarcopenia. So it's just a lose-lose situation. And then there's some struggles with mental health and stuff. And so there are studies where it shows as the reduction of cholesterol in your body, it will cause more mood disorders and anger and stuff. And so for those reasons, I thought it wasn't ideal beyond all the non-efficacy benefits of statins. But if statins only show a 3 to 4% benefit, but then there's a risk of causing more insulin resistance, is there any, even if someone wasn't going to change their diet, is there actually a benefit in getting on it? Because the risk is they can still become more insulin resistant.
Yeah, very good question, honestly. And I don't know that, we have a definitive answer to that. It kind of becomes a question of, And I'm going to put this out there as well. We have other ways of lowering your LDL cholesterol level these days. We have other medications that aren't statins that work by some different mechanisms, so they may have the same side effects. And I always caution that by saying we have less experience with those medications, so we really don't know for sure. But yeah, I mean, that's a very valid argument to make. It's just that when you're dealing with people who essentially don't want to improve their health, you kind of throw your hands up and say, okay, well, just take the medication and I guess take your chances with whether or not you're going to get those long-term side effects.
Right. My doctor friend told me it's taking calculated risk to treat the patient today. And even though knowing there are risks to everything, it's if my patient in front of me says they're not going to change my diet, and you know that there's risks with their, the not so ideal cholesterol, maybe in that scenario, it's the best, weighing all the risks in that moment. But the real goal is that they should, put their health in their hands and change their diet. But some people just have a hard time doing that. And so I see the dilemma as a practitioner completely.
Yeah. Yeah. I think the unfortunate thing from a practitioner standpoint is, practitioners have been put in the position of thinking, of believing that the only way that they can help patients, mitigate heart disease risk is by prescribing these medications. And again, nothing could be further from the truth. Low carbohydrate diets, addressing insulin resistance, are much more powerful ways that we can help people. But most practitioners don't know that. They're not aware of it. And it's not that they're withholding information from patients. They're truly not aware of it. And like I said, the only thing I heard in medical school and the first half of my career as a heart surgeon was, just lower the patient's cholesterol. And that's the way that we can deal with heart disease. Now, we've been giving that advice and we've been taking that approach now for 40 years, and it's not working. Heart disease is still far and away the number one killer here in the US and worldwide. So that's why I hope that more and more of my colleagues are waking up to that fact. If nothing else, I really hope that they're at least getting frustrated with the poor results that they are seeing in their patients.
Yeah, and I love that you speak up for this very reason, because when you say you're a heart doctor, people will listen more because it gives you that merit to say, look, I've been trained like all these other cardiologists that say you should get on a statin, and I'm saying that they're probably not right. And I love that. Do you happen to know the statistic? So I hear certain people that then get stents or they get some type of heart surgery. It's a matter of a very short period that if they don't change their diet, that there's a chance that they can die. Do you happen to know what that statistic is, or that they may need another heart surgery?
No, I'm not really aware of, an essential time crunch around that. What I do know is the unfortunate reality is the majority of people that get stents or get bypass surgery still end up dying of heart disease. They might die, later than they would have without the stent, without the bypass surgery, but they still end up dying of heart disease because when we put the stent in or we do the bypass surgery, we haven't addressed what causes the heart disease in the first place. And so that heart disease just continues to progress over time. And that's the real missed opportunity, I feel. Yes, of course, it would be great if we were preventing, heart disease in the first place. But absent that, when the patient shows up at our door with heart disease, the fact that we're not addressing the underlying cause of their heart disease is really just, I consider criminal at this point. And so, what I can say as a heart surgeon is I know that I am a much better heart surgeon today because I can say to that patient, listen, we need to do this heart surgery to deal with the problem that's in front of us right now. But if we don't address the underlying cause, it's going to continue to be a problem. And now I can give them the tools that they need to address the underlying root cause of their heart disease.
If I didn't have the funds to do all of this heart testing and get the scan, is there a way that I can just tell that maybe my heart's doing pretty decently if my diet's relatively good and maybe exercise if I'm doing cardio? I don't know if you think cardio is good, but
Yeah, well, on the exercise front, I would more emphasize, resistance exercise and muscle building and maintenance, which is really one of the most powerful predictors we have of both lifespan and quality of life as we age. But some simple things that people can do, I always point people back to the 5 basic measures of metabolic health. And 2 of these are free. You can measure your waist circumference. All you need is a tape measure, and you can get your blood pressure measured, every time you go to the doctor, go to your, almost every pharmacy, grocery store. I even see them in the airport these days. They have the little kiosk that you can go get your blood pressure measured. Although I would put forth the airport is probably not the best place to be measuring your blood pressure. But, so those 2 are free. And then, the most basic blood work, a fasting blood glucose level, an HDL cholesterol level, and a triglyceride level. And you can get those 5 numbers, and you can go to my website, free quiz, calculator right on the front page at ifixhearts.com. And you put in those 5 measures, and we'll tell you if you're metabolically healthy or not. So, very simple things that people can be doing. And, the other thing I tell people is, we know the answer. The answer is, low carbohydrate diet is going to, reliably reverse insulin resistance. So if you can't test, I would just default, let's do that. And that's going to give you the best chance of doing all right over the long run.
Well, thank you so much. I think you've answered so many of the questions that we as a practice and even as a community get in terms of heart health, especially when the cholesterol goes the wrong way, or especially with LDL going up. But it sounds like it's more the ratios of triglycerides over HDL, and looking at the LPIR score, other insulin markers, and then also getting the calcium scan if you're able to get that. And I think a lot of that is more predictive of heart disease than your just general cholesterol number. So thank you so much for your time. Where can people find you? You talked about telemedicine. So do you take insurance? How does that work? And how do they work with you, especially if they're not in where you're based out of?
Yeah, so iFixHearts is where to find me everywhere. All the social media channels, go to ifixhearts.com. You can find out all the ways that we work with patients. My telemedicine practice, like I said, we see people from all across the US and even internationally. We don't take insurance at the practice, and there's a very good reason for that. I want to work directly with the patient. I want to decide with the patient what testing we should be doing or shouldn't be doing. And I don't want the insurance company telling us what testing we should and shouldn't be doing. People need to realize that, yes, insurance might be covering the cost, but you're getting what you pay for. Right. And if you're not paying for it and the insurance company is paying for it, then the insurance company decides what you get and don't get. And oftentimes, what you get from them is not what you need to keep you healthy. So this does take investment. It takes investment in your time, and it may take some investment in your money, but that is going to have a very positive ROI, return on investment, in the long term. So we have lots of different ways that we work with people. Just come to ifixhearts.com and we can figure out a way to work with you.
Yeah, I think that makes so much sense. When I was still on conventional insurance, I asked my doctor, I think it was a nurse practitioner in the room, I wrote down all these tests that I wanted to take, including like C-peptide and all these other markers that I heard on the internet was good for low carbers. And they wouldn't run it because they're like, you're not at the age, you're not at this and that. And later I found out, as I started becoming and having my own practice, that because insurance agencies will then call them back and said, why did you run this? They weren't at risk. And then they won't even cover it. To not have to deal with that headache, these doctors or these offices will just cover what will for sure get covered, which is very, very minimal. And so I can see that pain and that headache. And so that's why so many people will not take insurance, because of they want to give you the proper care. And when you're part of an insurance or a network, it really straps your hands and you can't really do much. So I totally get it.
Yeah. And one other thing for people to understand on that front is oftentimes this testing is nowhere near as expensive as we're led to believe it is. There are very cost-effective ways to do this. And, I encourage people, in a lot of places, certainly here in the US, with a couple of exceptions, you can go order your own labs from, certain websites and get it done very inexpensively. A fasting insulin level, for instance, is going to cost you less than $20 to get checked. So very, very worthwhile investment, I think.
Right. I totally agreed. Well, thank you so much for your time. I'm excited to see you at KetoCon and it'll be great. So thank you so much again.
Yeah. Thank you, Judy.
Okay, guys, I hope that you enjoyed this interview. I hope it taught you a lot about what really goes into heart disease and other factors beyond just the diet that can affect heart disease. There are many ways to consider if you have a good heart health, and Dr. Ovadia talked about many different facets that you can consider. If you left with anything from this interview, I would highly recommend not to just consider one marker as the indicator that you have heart health or heart disease or not. In fact, if you just looked at the LPIR score, or if you just looked at your fasting insulin or your fasting blood glucose, these are not just the marker to look at to see if you may have heart disease. There are many facets that go into heart disease, but one big one is insulin resistance. And the more you are insulin resistant, the more that you are struggling with obesity, and the more that your LPIR score is high, there is a higher chance that you will have a heart event. This information is not to scare you, but to give you the empowerment to do something about your health. But one thing for sure is that it is not just saturated fats alone or meat alone that is causing heart disease. This is an old food that has been around forever, and yet heart disease is a new illness. So sometimes it's just simply putting on a logical hat to know that maybe it isn't just saturated fats or cholesterol that is causing heart disease to occur. Maybe it's a lot of the other new things we've introduced to our diet and our lifestyles that are making us sick. Okay, guys, make sure to eat a lot of meat. Take care of your bodies because it is the only place you have to live. I will talk to you later. Bye, guys.